Good afternoon, everybody. It's a pleasure to have, after the lunch break, this new session. The session this morning was really great, with a great first great lecture by Professor Calder, and very nice lecture from the member of the consortium. And now we have a new session and the second keynote lecture by Professor Margarita Calonge, with an expert, a worldwide expert in the field of dry eye. And she will talk about the implication of dry eye and the pathogenesis of dry eye. Please, Marga.
Thank you, Professor Baudouin and his team for hosting us and for the invitation. So under this pretty vague title, what I actually want to discuss with you is several points, several items that might help explaining why we have so few drugs in the market for our dry eye patients. So let's just go one by one. I mean, the list could be much longer, but I just selected these topics. What about the first one? We know a lot about the pathophysiology, but we actually don't know the etiology. We know that dry eye disease is a multifactorial disease of the lacrimal functional unit, and we have this beautiful cartoon designed by our dear Michael Stern. We know that the pathogenesis is an immune-based inflammation, thanks to many people like him and like Christophe Baudouin, actually. We also know that there are neurosensory abnormalities, all contributing to this dysfunctional tear film, the damage to the ocular surface, and explaining all the symptoms and signs of dry eye. We know that there are many risk factors. This list could be endless, but not everybody having depression or using video terminal displays or under adverse environments have dry eye. So in addition to this, we need something that we might call first hit, meaning that there has to be an antigen, something to which we develop a immune reaction that is supposedly genetically determined. But we don't know that yet. So again, just to summarize this first issue, we know what the normality is. We know that we can have dry eye through one of many combinations of these, a decreased amount of tears, alteration in the lipid layers, inflammatory molecules in the aqueous layer, disruption of the epithelial surface, anomalies in the nerves, in the corneal nerves. We know a lot about pathophysiology, predisposition, clinical background, but we don't know the etiology. So we can only have remissions, but we can have a cure if we don't know the cause. What about this, the multifactorial nature of dry eye? This is in the definition, we talked about that. But I'm just going to show you, because I'm a clinician, I'm going to show you this with pictures so that you basic researchers people understand that something that was said more than 30 years ago by a famous clinician, that not only acute problems, but mostly any chronic ocular surface inflammatory disease may eventually develop into dry eye. For instance, we can have dry eye after chronic chlamydial infection. We can have dry eye after chronic Epstein-Barr virus infection. We can develop dry eye after an acute episode of adenoviral keratoconjunctivitis, of course, in the context of pterygia, lupus. Atopic keratoconjunctivitis is a disease that could develop dry eye because it's chronic, but it's also amazing the fact that this, in my experience, is the diagnosis that often gets more confused with dry eye. Some patients come to me with the diagnosis of dry eye, and they don't have dry eye, they have AKC. And amazingly enough, these patients may have normal Schirmer tests, but dryness is one of the main symptoms too. And of course, we can have dry eye as an end stage of this chronic immune-based chronic cicatricial keratoconjunctivitis, such as pemphigoid or the Stevens-Johnson syndrome spectrum. All of this will cause dry eye or can cause dry eye. And is it important to know the reason, or it really doesn't matter because dry eye is treated the same whether it is from this source, this source, this source? It is really important. And let me just give you this example. This was a and this is a real case. This is was a 38-year-old male coming to see me because he was diagnosed of Sjogren's syndrome. So I said, a male Sjogren's syndrome, so young, that wasn't the case. I mean, that's weird, to say the least. So doing a clinical history, which I think you would agree, Christophe, that is the best diagnostic tool that we physicians have. In the clinical history, he told me, oh, by the way, my wife is having the same symptoms, she just couldn't come because she's in another consultation. So I scraped this guy, this conjunctiva, and this guy didn't have Sjogren. This guy had chlamydial infection. And the difference is huge because this guy was totally cured and not going through all the immunosuppressive local treatments for a supposedly diagnosed Sjogren's syndrome. So the etiology is very important, and we need to make efforts to diagnose what the cause is if we can have it. Once we know that our patient has dry eye, then the clinical spectrum is very broad. We already know about these different types: aqueous deficient, evaporative, mixed. Most of the times, each of these could be caused by many diseases here in the boxes, but each could be caused by several diseases. But again, I'm going to show you in clinical pictures what this broad clinical spectrum may mean. We can have a very, not very symptomatic with just some conjunctival staining, and this is dry eye too. We can have the most typical and most frequent clinical picture in our clinics, which is meibomian gland disease, typical alteration in the lipid layer with sometimes not conjunctival corneal staining, with some corneal staining. This is the most frequent presentation of dry eye, actually, with normal Schirmer tests, normal production. We can have Sjogren's, primary Sjogren's, with very variable clinical pictures, little staining, filamentous keratopathy, big epithelial defects, corneal ulcer. All of this is Sjogren. Look at the difference between having this or going to this. We can have secondary Sjogren's syndromes due to rheumatoid arthritis, for instance. And this lady actually had Sjogren's for 20 years, well controlled with just artificial tears and gels and ointments. But all of a sudden, she developed a complication of rheumatoid arthritis, which is peripheral ulcerative keratitis. This is a vasculitis that puts this eye at risk and her life at risk because she could have vasculitis in any other viral organs. So after a year of immunosuppression with cyclophosphamide at that time, she was controlled, and this is the same picture years later, but from that point, she couldn't get rid of cyclosporine, steroids from time to time, blood derivative products, so her dry eye became really much worse after having this first episode, and I'm sure Mike and Virginia will have explanations for this. And we can have also dry eye from this very severe disease, graft versus host disease, which is the disease that people who have bone marrow transplants for their hematological malignancies develop. And I'm sorry, I was keeping this too low, sorry. So as you see in this picture, the spectrum, the severity, clinically speaking, is so broad. This is dry eye, this is also dry eye, and this, and this, and this. What do we know about the progression? Because we always think, well, dry eye is a progressive disease. We actually don't know that. We don't know what the patient journey is along this year. Is the disease going to progress? Can the disease going into remission? Can the disease be cured? Well, all this, the journey through this arrow has been defined Typhus already defined what is predisposition, what is preclinical dry eye, symptomatic or established dry eye. But this doesn't mean that a patient is going to go always from here to here. A patient can start here, stay here forever. I mean, the variations are tremendous. We actually cannot tell this young patient, starting with preclinical dry eye, having only symptoms, that she's going to end up like this if she doesn't receive treatment. We just don't know whether she will progress or not. Similarly, we cannot tell this elderly lady who started an established dry eye, we cannot say, well, if you don't get treatment, you are going to stay like this, but if you get treatment, you will get almost asymptomatic. That's what we tell our patients, that you are going to get better if you get treatment. You should get treatment for sure. We need to do every therapeutic effort that we can, but we cannot always, never be sure that our patient is going to progress or is going to go under remission. So in summary, we don't know yet the progression. And actually, when I looked at publications about that, I found very little. And I selected this one, which is the proof study, and I actually selected it too because Mike is here, Steve Lufeller, so he might correct me if I say something wrong. They did study in the United States from all these places that you hear in this map, collecting 5-year natural history of dry eye with the hypothesis that dry eye will be a progressive condition. So it took them 8 years to publish this paper, to collect data from the baseline of these patients. They published in 2017 this, and this was the conclusions. 60% of the people had severe blurred vision, greater reduction in work and non-work productivity than controls, greater need for visits to ophthalmologist. But from this point, they were supposed to be collecting data so that we can have a 5-year natural history, which will be due next year. So if they don't publish this, we wouldn't know, we just will know what happened 5 years after. So in summary, if the natural course of dry eye is not fully known, then the long-term efficacy of therapies will always be questionable, at the very least. What about the dependence of external environments, which is something very particular, very unique about this ocular surface disease? It is already in the early definition of classification on dry eye in 2007 that the external environment affects dry eye. Let me walk you through this slide. This is just to show you that dry eye patients and also healthy subjects have a variation in their ocular surface parameters depending upon the humidity, temperature, airflow, these 3 conditions mainly, but also atmospheric pressure, ultraviolet radiation, and pollution. These are actually the conditions recommended by the American Association of Engineers, and this is taken as the protocol that any building has to have a healthy environment. We know that if the temperature or the airflow or the altitude increases and or the humidity of the atmospheric pressure decrease, we'll have an increased evaporation rate of our tear film. Consequently, the tear film stability will decrease and we might be prone to develop dry eye. And look at these two graphs here. We are under a nice temperature of 25 degrees, but if we add moving air, if we add moving air to the same temperature, look at the increase in evaporation. So dry eye, air moving around our faces is a great factor to increase the evaporation of the tear film. Look at this graph here. We have evaporation versus humidity. So if the humidity increases, such as when we are near the sea, the evaporation is almost none. But if we go to drier places, having 30, 20% humidity, the evaporation is a lot, is greater. So after knowing that, we did this work, and I'm going to show you this just to as a kind of proof that outdoor environments are important in dry eye. And Maria was the main supervisor in this, the doctoral thesis of Marisa, so correct me if I say something wrong, Maria. We designed this study for the 3 months that she had to be abroad for her doctoral thesis. So we analyzed a series of healthy people, students, young people, in our place where we live, Valladolid, with the weather is continental, and we did the same, Jesus. we did the same study with a similar population, statistically exactly the same population in Braga, which is near the sea in Portugal. We did it in such a way that the only variable was the humidity, very low here. Where we live in Valladolid, if we are lucky, we have 40% humidity. It's almost 80% here, 90%. So the only variable was humidity. What we found is that all the tests for dry eye were worse in these healthy people when they were tested in Valladolid and when the tests were done in Braga, near the sea, proving that dry eye test outcomes are climate dependent. And you might be thinking, why is that important? Because if we're running a clinical trial in Valladolid or in Braga, the results could be different just because we are in different environments. What about indoors? Where indoors we live in artificially controlled environments where humidity is low, there is air conditioning, the air is moving around our eyes, and we might have also high altitude if we're flying. And we have this in our homes, in workplaces, in vehicles, in recreational facilities, shopping centers, airplane cabins. And it has been demonstrated already that this that you see here, burning, dry eye, photophobia, asthenopia in sick buildings, air conditioning buildings, where we are right now, the conditions get much worse than in the old, naturally ventilated buildings, meaning again that the conditions that we have in the room where we are living, examining our patients, might be worse than if we have, depending on the kind of room we are. So in summary, the variability in ocular surface symptoms and signs with environmental conditions is a well-recognized problem in dry eye, and the consequence is that it will interfere with valid and reproducible results in clinical trials. So one way to try to sort this out is to evaluate patients in controlled environmental laboratories where we can control all the variables, and we can do all kinds of tests there and take any kind of samples and actually customize our clinical studies. We can have in this clinical, in these control laboratories, we can have our patients exposed for a while to what we call control normal conditions, so that each patient is normalized to avoid the bias of temperature, humidity, misleading to bad results in clinical trials. We can also have these patients exposed to adverse control environmental conditions, and we know that by doing that, our patients are going to get worse. And we actually demonstrated that with all these papers. We proved that patients under 2 hours in this controlled adverse environment, they got worse clinically. Their eyes were redder. You see some eyes here. Their clinical staining got worse, and some inflammatory molecules, interleukin-6, EGF, and MMP9 were altered. But we needed to see if some drugs could reverse the situation, and we did that with this drug, an steroid, fluorometholone. So we administered this drug to our patients. We did clinical and molecular study. I'm just summarizing here the clinical staining just to show you that it would be great if the drugs that we designed for dry eye could not only improve our patients in a good environment, but also in these rooms we spend most of our lives actually nowadays. So see the clinical staining. After these patients got fluorometholone, these patients got the vehicle. Of course, the corneal staining got better with fluorometholone, and when these patients went through 2 hours in the environmental chamber, their staining was the same, it didn't increase. But in these patients with the vehicle, the corneal staining increased in these 2 hours of adverse environment. So now that we established that, which is very important, we'll try to answer these 2 questions. Why do therapeutic clinical trials in dry eye fail so often? Well, we could have a 7-day workshop and talking about this and not be finished, but I just have 3 slides about this. One of the reasons and why I was speaking about the spectrum of dry eye is that this highly heterogeneous disease, in this disease, is very difficult to demonstrate results in clinical trials. We have already covered that. We have multiple coexisting causes, multiple severities, etiology unknown, natural evolutive course also unknown. But we have a great difficulty in evaluating symptoms, and this is a very symptomatic disease, and the regulatory agencies need not only the improvement of at least one sign to approve a drug, but also they need to see an improvement in symptoms, both. And symptoms are the problem. Not only the symptoms, but symptoms are a real problem because it's very difficult to evaluate symptoms, as you may imagine. When we have a disease with multiple symptoms, which one do we use? Which one we choose? There is a frequent and well-known disparity between symptoms and signs. Symptoms may not correlate with signs, and I'm giving you these 2 real examples from real patients. This patient, you see that has a little bit of a staining. This patient, I guess you would agree that this cornea looks worse than this one. Well, this patient was feeling horrible, she was miserable. This patient was okay. Amazing, but it is like that. So you can see the difficulty in clinical trials when this patient is happy already with this cornea and this patient is very unhappy with this cornea. We also have confounding symptoms due to, for instance, overlooked dry eye components, and meibomian gland disease is the perfect example. Many aqueous deficient dry eye have meibomian gland disease associated, and it is almost the case in 100% of Sjögren patients, for instance. Clinical trials often overlook this component, and this might be a big reason for failure. And we know examples of failure of drugs due to this problem. Another problem is that we have, and this has been proven also, that patients that were thought to have dry eye were included in clinical trials, and they didn't have dry eye, they have dryness as a symptom, but the disease, the background disease was not dry eye, it was often AKC. There are many other reasons. For instance, the confounding factor of patients' load of visual tasks. Higher people with higher demands on visual tasks, young people working, reading, computer using, smartphones, etc., they will have more symptoms than people which life is not so much based on these visual tasks. Putting all these people together in clinical trials may have also an important bias. The confounding factor of external environments, we already talked about that. Also, this disease, dry eye disease, these patients use a lot of palliative methods. They never tell us about it. They don't say that in clinical trials when they are being questioned about exclusion-inclusion criteria. Many of them use herbal, nutritional, dietary supplements, and this could be also a problem for the results. There could be also limitations to the techniques available to evaluate our outcomes, and that's why we need to find objective and reliable biomarker that really measure the mechanism of action of our drug, and Christoph alluded to that earlier. There are many groups working in biomarkers. We work, as you know, a lot in biomarkers in tears, in cells. Many other groups work also in these markers, in imaging techniques, and we are going to hear one of you young people speaking about that later. There is a final thing sorry, I did that again. in dry eye, and this is the placebo response. The placebo response is particularly enormous in dry eye, in therapeutic clinical trials on dry eye. And this is because a good clinical trial, therapeutic clinical trial in dry eye will have to be vehicle controlled. That will mean some patients receiving the active drug in their vehicle and some others receiving just the vehicle without the active drug. But the active, the vehicle of the active formulation of the medication could be, could have a good, also a good, could be a good treatment for some of these patients. This is called placebo response, meaning an unexpected beneficial effect of some vehicles, especially vehicles that are elaborated because the drug requires these elaborated vehicles. This could be due to many reasons. One of these reasons could be that when a patient enters a clinical trial, this patient becomes more compliant. Instead of putting the artificial tears maybe twice a day today, 4 times tomorrow, 5 times next day, they are ordered to put it more regularly and they become more compliant. Also because of the inclusion-exclusion criteria, they have to discontinue some concomitant medications with preservatives, for instance, and they may improve because of that. But there is some real inherent beneficial of some elaborated vehicles. And as Mike can tell you, the vehicle for cyclosporine, when he was in Allergan, was commercialized because it was a very nice vehicle. Also, the vehicle for the cyclosporine that we have in Europe now is in the market because it happened to be a very efficient vehicle. So if the placebo response is large, the statistical power is less, and this could be a cause of failure in clinical trials. And finally, what are the problems, the pitfalls in translating preclinical research, the preclinical research that you are doing into clinical trials? Well, if one looks at the all the possibilities of the therapeutic scheme in dry eye, one might think, wow, I have a lot of options. What are you talking about? There are a lot of things that we can do. But if we select things that eye drops, things that we can put in our eyes, in our nose, and this product has been just approved by the FDA, or taken orally, the list is less. If we actually select things that we know are specifically accepted, approved for dry eye, the list is shorter. And if we actually select things that can be working topically, we only have anti-inflammatory and immunomodulatory agents. And we might think that we have a lot of that, but we don't. We only have steroids, and most of them are off-label, but we use them. And we actually only have here, where we are in Europe, topical cyclosporine. Tacrolimus is not available. Leaf-eater-grass is not in Europe. I think France has the possibility to use it somehow, but or not. Gustav is shaking. I heard. So again, yeah. In summary, when we are, sitting with a patient in front of us, we can only give as drugs steroids, which can be not long-term, or cyclosporine. And if this patient does not tolerate cyclosporine, we just don't know what to do. So why then, in summary, we seem to have a lot of drugs for our mice, our rats, and very little for us, human beings? Well, many drugs with excellent preclinical data never make it to the proof of concept clinical trial. And these proof of concept clinical trial are essential to have these drugs in the pharmacy so that our patients can buy them. There are many reasons, and again, we could be here for a week explaining that, but this is the message that I wanted to give you all, new young people. Well, some candidates that you are working with right now may be very good for the mice, but not be good for the human. And this is just the way it is. Mice and humans are not the same. And if we never go to these proof of concept clinical trials, we will never know. So some good drugs for mice don't work for humans. Also, and sadly, this is the case many times, some or many investigators stop where the preclinical work is done, the papers are published, the doctoral theses are defended, the PhD degrees are gotten, and they never think about, well, wouldn't be a waste of money, our money, the taxpayers, and a waste of animal lives if we don't move ahead. I know this European consortium did not contemplate translational part, but we just can't stay here where we are and not think about the products that you're working with to just take them to our patients. It might be difficult, it might be complicated, it might be a long word, but I really believe that it would have been a waste of time if you don't move ahead. And I'm looking at you young people, but I have to mainly look at these people, not so young people in the supervisory board. We are the responsible one. We need to move these products ahead. So with that, I'd like to thank you young people for all the work you're doing. We need you to push us to go into the clinical area with your products. And I'd like also to thank the external advisory board. And of course, we couldn't be here without Maya and Path work. So I'd like to thank them, although they cannot be here for reasons that you know. And thank you very much for your attention and your invitation.
Thank you very much, Marga, for this.
Take my mess off, sorry.
Not a problem. Thank you very much. Very, very, very nice lecture. Very practical, because this comprehensive overview is important for our young people to better understand effectively that it's not so difficult to identify targets for treating dry, but it's so difficult to make them into practice. And if I can compare with another ocular disease like glaucoma. Glaucoma, in my opinion, is a good example, because to develop dry product is as difficult as in glaucoma, but not glaucoma and IOP, glaucoma on neuroprotection. Yes. Neuroprotection is a nightmare for companies. All of them have failed in developing neuroprotective agents. We have very good example with extremely powerful proof of concept, very nice targets like memantine, for example, like brimonidine. But at the end, to translate that into clinical trial, it's extremely difficult, because you have to deal with subjective evaluation. We have to control all other product. You have to you have patients who are more prone to be more compliant. The placebo effect is very important. And at the end, it's extremely difficult. Fortunately, my example on glaucoma is aimed at showing you that what is convenient for developing new drugs is to have a surrogate marker that can be accepted by the authorities. In glaucoma, the surrogate marker is IOP control, intraocular pressure control, because the authorities and the scientific community agrees on the fact that if the IOP is well controlled, then it's considered as neuroprotectant. So it's not necessary to wait for 10 more years to show that the visual field will be protected. But the debate about which marker could be used, for example, for neuroprotection, there is some advices to use OCT as a marker. If we control OCT, does it mean that it could be a good example, a good marker of protection of the optic nerve? Maybe yes, maybe no. I know that the FDA is not yet accepting OCT as a surrogate marker for neuroprotection. Here it's extremely complex for all the very nice reasons you have mentioned, but also because the authorities require a dogma. You must improve both the sign, whatever the sign you choose, and the symptom. The problem is that there is a major discrepancy. So to get improvement in both is extremely difficult. And I remember 2 studies by Santen about the development of iCurvis. It has been published, so I can talk about that. there were 50% of the patients responding well, both to the sign and the symptom. Good. There were 20% of patients responding to the sign, but not the symptom, and 20% responding well to the symptom and not to the sign. When you have only 50% were more or less consistent with a huge placebo effect, it becomes very difficult to get to the two. And the FDA has understood this message, but in my opinion has not solved the problem, because they decided that if you improve the sign and only the sign, the only marker that could be acceptable would be a total clearing of the cornea. But if you start with a Sjogren with very huge keratitis and corneal damage, and you just analyze the few people who will be totally cleared. But totally cleared, what does it mean? Grade 1 by Oxford is almost normal. You take your shower, you put 1 drop of fluorescein just after. I'm sure we will find plenty of few dots on the cornea. So total clearing 0 is at the limit. It's below the physiology. So of course it's very difficult. And just to finish, and sorry if I am a little bit too long, but it's a domain I am rather motivated. But a new one. There is a confidentiality agreement, but I can probably share an interesting information. There was recently a study on an immunosuppressant agent that was shown to be efficient in a subpopulation of patients with a specific SNP, which means that genetic factors, you were suggesting that genetics could be also important to consider. It's absolutely true. But genetics could also influence not only the disease, but the response to a specific agent. So the nightmare is not over. Is there any question? Yes, Annabelle.
So there is a question from Philip. Great seminar. And one comment, there are also drugs that are promising in clinical trials and fail in real-world clinical practice.
I didn't get your question.
Yes, there are also drugs that are promising in clinical trials and fail.
Azithromycin?
Yes, in real world, in the clinical practice. So there is also...
And I think the reason is very simple, because they are very badly tolerated. Azithromycin topical is very difficult to tolerate. So if the drug is efficient, but the patient cannot tolerate it, it's just not a good drug. I mean, number one thing is the eye couldn't get so inflamed and irritated that the patient just hates the drug. So I think that's the reason why it failed. I mean, I used it twice, and patients wanting to kill me, so I decided not to use it anymore. I mean, and this is true. What are you giving me? Why are you giving me this? Supposed to work orally too, but I saw a hand.
Really good presentation. I really love it. I have a question about the placebo effect, because it's the I don't know if there is some studies about the placebo effect in eye drops, for example, or any treatment for dry eye or the ocular surface in general. And if this placebo, they look at the symptoms only, or they look at also the signs, and also if there is a way to differentiate the effect of the vehicle, because if you are trying to measure the placebo, you have to give something to the patient.
Yeah, of course.
Is there any way to...
Well, the clinical trials always, the ones for registration purposes, and man looking at Mike because he knows a lot about that. He works in a pharmaceutical company, so correct me if I'm wrong. But for a registration purpose, you need to do a vehicle controlled. So patients, some patients have to have the active drug plus the vehicle, and some others the vehicle, and you have to show a difference. The problem is that some vehicles, for instance, cyclosporine vehicles, which have to be very well elaborated because cyclosporine is difficult to make, to dissolve and everything, the vehicles are so good that they also have an effect. And to show a difference, it was actually the reason for some clinical trials to fail. And in fact, as I said, these vehicles were commercialized later, and they are in the market. And it's very tough. We always have known that cyclosporine is a very good drug. We have used it many years, for many years compounded, more than 50 years. We have used it in any ocular inflammatory disease, but to have the proof that the regulatory authorities required, it was so tough. He only can tell you how tough it was to get cyclosporine accepted when we know it works. So.
Adrian, effectively, in terms of pain, there is a huge placebo effect. We know that it may perform as well as any kind of painkiller. But in clinical trials, the placebo is never a placebo because you treat dry.
Yeah.
And I remember discussing in companies developing IOP lowering eye drops, and they found that the placebo has an effect that can be up to 15% of reduction of IOP. How can it work? It's difficult to understand that. So it's a very, very tough. And I remember Mike was there. We were in 1998. I was one of the external panel of experts for cyclosporine. And we were expecting, and we got the very first results of the very first study, multi-center trial on cyclosporine. And we were eager to get the results. And we had the result. And the results were good, but we were expecting excellent result with Restasis. We were expecting a huge effect of the cyclosporine compared to the vehicle. And we had the relatively bad surprise. The difference was interesting, but not so much. And I remember I was with Tony Brown, and the expert of the group from UK. And when somebody at Allergan told us, "What do you think about the result?" We told, same word, same moment, same minute, Tony and I launched the vehicle. And it was Refresh Endura, the vehicle, castor oil. Karima.
Thank
question?
you for your presentation. It's always very interesting, but finally, I'm feeling always sad because I said we have a lot of we perform a lot of work at the bench. We have a lot of ideas, a lot of biomarkers, very interesting biomarkers. But after we know that it could be impossible to translate to the human. So we have like a note. We have different notes. But I think that sometimes it's perhaps better to increase the stratification of patients before starting these clinical trials. As said Professor Baudouin, for sure, if we have genetic differences, it's clear that the responses will be not the same. So what can we do before? What can we do in the notes and before clinical trials?
Well, I actually have many more slides explaining the solutions that have been given to each of these problems. I just decided that it was going to be too much, and it wasn't the purpose of this group to have how to improve clinical trials. But all these problems are known for long, and there are techniques and things that we can do now to improve the results of clinical trials. And this is well written already, so I can give you bibliography you want, and the stratification is one of the problems. As long as you don't get too small groups, stratification is one of the things. But our problem here is before that. I mean, before we go to clinical trials, we have to have the olive oil thing and the marine stuff, anything that is worthwhile, just having a proof of concept clinical trial, which will be 20 patients versus 20 patients. Much better if we do it in an environmental controlled room, and we need to explore everything that has to be explored, everything to know what the signal of this particular component is. Because you might think that a component is very good for clinical staining, for corneal staining, and it might be very good at other stuff, at decreasing interleukin 6 and MMP9s. So you have to find the signal for each compound. And this has to be done in smaller clinical trials, the proof of concept clinical trials, before going into multi-center, millions, spending millions, not knowing what you're looking for. That's a strategy that is becoming more and more evident right now.
Thank you very much. It's time to move to the next session. I want to thank you very much for your great lecture. I also want to thank our director. We have the general director of the hospital with us. It's an honor for us. Nicolas Péju, thank you for coming for this session and for being in this scientific area.